Advanced Trauma Life Support. When I say ATLS, what is the first thing that comes into your mind? Trauma. Okay, very good, excellent. That's good for a start. Trauma. Okay, what else? What else? When I say Advanced Trauma Life Support, what does it mean? Life-threatening, something that's life-threatening. What is more life-threatening than Justin Bieber? Okay, so what comes into mind? You want to look for life-threatening injuries, but what about life-threatening injuries? I can just when patient come to trauma, I just assess for life-threatening injuries. But what makes ATLS so special? Because ATLS was designed, put into place to detect life-threatening injuries immediately, so that we can treat them immediately. Because before ATLS, the mortality was very high. Patients come with trauma, we don't have a systematic approach to trauma. Mortality used to be very high because we used to miss life-threatening injuries. So ATLS is put into place just for us to detect life-threatening injuries. Okay? Alright. Now, when we talk about ATLS, okay, how many of y'all have been in red zone and have managed the ATLS patient? Pernah? Semua ada? Semua pernah? Semua ada? Demo? Ada, eh? Okay, very good. Excellent. Alright, okay. Okay, now, when you deal with the ATLS patient, what you see, how do they do it? What is the first thing you see them do? Okay, airway. Okay, so how they usually assess the airway? Talk to the patient. Okay. Then patient response. How you grade this response? How you know if patient is talking, it's okay. Patient not talking, certain amount of talking, not talking, merapu. How are you going to know? Yes, our star of the show finally here lah. Yes. Come. Please join us. Okay. Come. Have a seat. Okay. Tepukan. Bagi tepukan. Okay, alright, bro, breast. Okay. Alright, now, what is our question saying? Very short memory span. Yes, so how do you grade response? Orientated, time, place, person. You see, the thing about ED, right, what makes us special is that for everything, we have a system. We have a mnemonic for everything. You see, we have to work so fast that you cannot be like, patient dying there, what is this? Medical difference, that's a different story. I think I'm going to edit that out, okay? Medical different stories. Okay, look at this one. There's scoliosis, kyphosis, there is a hyposteoarthropathic, they'll go on and on, okay? Medical is different, okay? Harap tak ada orang sini yang ada relative kat medical, alright. They can take all the sweet time in the world, dance and come to a diagnosis. But we know, if you delay, patient is only going to be worse and worse, and before you know it, poof, 6 feet under. Correct? You have dealt with that situation before, right? Patient just deteriorate so fast. Some patients come so relaxed, suddenly pop, deteriorate. You know. So because of that, we will have to come up with a very good system. Patient come, what is the mnemonic to see whether patient is responsive or not. Okay? All this, we have a system. So today, what I'm going to do is, I'm going to simplify ATLS for you, give you a system that you can remember, and make sure that when you go back, whenever you deal with a trauma patient, you do all these steps which I teach you. Okay? Very easy to remember. Just like post-discharge care, head to toe. Ingat belaka there. Betul? Okay? You all remember everything. So same, post-discharge care, just like post-discharge care, ATLS, we have a system from the beginning until the end, and you have to follow the system. You know why? You will go to district one day. Betul? In district, sad to say, you will be alone. Okay? Although Liverpool says you will never walk alone. Okay? But in district, sometimes you have to walk alone. Because they already think, hey, this will finish housemanship. He is very good. He can survive as an MO. No problem. Let's throw him into the sea and let him swim. Okay? And that time, we'll be like, help. Call here, call there, call here. Then call your, and then semua tak jadi. Call your parents or siblings yang ada medical background. Abah nak buat macam mana ni? Mak nak buat macam mana ni? Okay, correct. That's what happens, right? Okay. So, Trauma patients, when you follow this system, you will be able to stabilize them well enough for transport. Okay? So this knowledge, this ATLS knowledge you're going to get today, you will carry until your grave. Okay? And it is something that very easy to follow, and you will benefit, and I assure you, you will be able to use it after this. Okay? But you must use this system that we put into place so that you will give the best management possible to your trauma patients. Boleh? Better? Okay, let's start. Now, it always starts with, okay, kalau BLS is DRCAB, betul? D stands for danger. R, response. C, DRS, shout for help dulu. Betul? Betul. Yes. Thank you. It's always DRS, doctors CAB. Okay? DRS, shout for help. Okay, then after shout for help will be circulation, airway and breathing. For ATLS, it's almost the same, but we follow the same order, which is the normal order, which is D, R, A, B, C, D, E. You can go on FGH, IJ, but this is the most important essential. And we have adjuncts, 2 plus 2 plus 2 plus 2. Okay. Forgive me for making this into a preschool thing, but this will help you to understand the adjuncts. Okay. So D, R, A, B, C, D, E, 2 plus 2 plus 2 plus 2. Okay. And remember, for each component of the ATLS, we have a partner. Remember, good things always come in twos. Okay? Husband, wife. Yin, yang. Klate, budu. Okay? Alright. Okay. This kind of things. Okay? Good things always come in twos. Evil always come in 3. Back's triad. Shakut's triad. Pernah ada triad yang bagus? Is there any good triads or not? Very rare. Very rare you have good triads. Usually all is bad triads. Isn't it? Okay. So now, when you talk, okay, so we will go into the twins a little bit later, okay? Okay, so now, first thing is danger. Usually what will happen, there will be a MVA somewhere, polytrauma. Your paramedics inform you, very bad MVA case coming. Patient, so. I don't know how you can see that from the front, okay? Patient, patient unconscious. Be prepared. So what will happen to you immediately? What's the first thing that happens? First thing will be, why this has to happen during my time when I'm on call? Why you start screaming to the skies? Okay, that's the first thing that you do. Okay, then what's the second thing you do? Kenaling. You start having palpitations. Betul? Okay, you start having palpitations and you are the only one there. Okay, so remember, first thing is danger. You have to protect yourself from danger at all times. Remember, even in pre-hospital or even in hospital. So how exactly you prevent yourself from danger in hospital? Pre-hospital, yes. There is a slick of oil on fire, and then you go there, you think, I'm Superman. Okay, then you fly to rescue the patient, and that patient get burned, you also get burned. Okay, so you need to always assess, stay away from danger. Okay, in pre-hospital. In hospital, what danger are we talking about? Angry MOs and registrars are not considered danger. Okay, dangerous to our emotional well-being, yes. Okay, so we are talking about personal protection, PPE, personal protection equipment. Whenever you hear a call, a trauma patient is coming, or you see a trauma patient at your doorstep, you must make sure that you immediately wear a personal protective equipment. So what is it that you wear? Gloves, goggles if there's goggles, okay? What else? Apron, gloves, and not only you, but your team as well. Your whoever paramedics or nurses that are helping you, make sure everyone wear PPE immediately, alright? Because you don't want to expose yourself to danger. That's why always start with danger first. You receive a call, yesterday first thing is PPE, personal protective equipment. Next is R. What is R? Usually is response. Yes, we will be assessing the patient's response when the patient arrives. But there are two things about R. One is response when the patient arrives, but before that, what is the other R? Role. you want to define the role of your team. Why? When patient comes, if you are the only one, you want to settle the airway, breathing, circulation, you want to prepare for intubation, you want to put the cervical collar, you want to put everything, you are running a one-man show. Unfortunately, this is not a Hindi movie or a Bollywood movie where one fella can take out 40 fellas. Okay? Alright. Unfortunately, that cannot happen in real life. In real life, you need help. You need to work as a team. But your team will not know what to do if you do not assign the roles properly. So whenever you get a trauma patient coming in, get your team together, red zone you have, right, staff nurse and paramedics in charge. Get them and assign the roles very properly so that when the patient comes, everything is smooth. They know exactly what to do. And you as a team leader should be able to tell them exactly what to do. So as a team leader, what are you supposed to do? So first you're going to tell them that, okay, you, Miss A, you will be in charge of airway. Please prepare all the airway apparatus such as you'll be in charge of airway plus cervical immobilization. Please prepare the cervical collar, prepare the intubation set, prepare oropharyngeal airway, suction, all apparatus that is needed for airway and cervical immobilization. Thank you very much. Okay, now, B, breathing. You will be preparing chest tube, helping me to assess the breathing of the patient, and also prepare all the other apparatus such as pericardial synthesis, apparatus for needle thoracotomy, and so forth. You will be in charge for circulation. Circulation, please, when the patient arrives, put 2 large bore granula, put 1 liter of warm normal saline, send all the bloods for GXM, put on the BP cuff monitoring, and please monitor the BP and keep informing the BP from time to time, at least every 15 minutes. Okay, or only from time to time lah. Okay, and then breathing, don't forget, put the patient on SpO2 monitoring and also inform me the SpO2 monitoring from time to time. You will be the runner. You will run and get us the blood and also help us in for all our procedures. Okay, cleared up, isn't it? So there is a system. Everybody knows what they need to do. So when the patient comes, airway knows what he's doing, breathing knows, he knows what to do, C, runner, everybody knows what to do. Otherwise, it will be a total chaos. Okay, it will be a total chaos. They all be standing, staring at you, wondering what the hell are you doing. Okay, you all have seen before, right? That kind of scenario. Okay, alright. So I don't need to explain more. Okay, now, so that is role. So first danger, PPE, settle. Next is role. Then the other R is response. Patient finally arrives. Your heart rate from 90 become 120. Okay, borderline going to 150 SVT already. Okay, alright. Now, patient has already arrived. Once patient arrives, what is the first thing you should do? Okay, of course, transfer him into the bed. Okay, remove the spinal board. Okay, if indicated, if not indicated, you can remove the spinal board. Okay, transfer him to the bed. What else you need to do at that time? What do you want to assess? The other R. How do you assess response? Call patient. Tampar dia. Oi, bangun. Do you slap him? No, right? Okay, okay. That's abuse, huh? Okay. So, what do you do? Tap on the shoulder, right? Do you assess GCS at this time? Why you don't want to assess GCS when patient first arrives? Yes, in ATLS, we do not advocate doing GCS during the arrival of the patient, because you are going to waste time. GCS takes time. You have assessed GCS, right? Oh, what's the E? The fellow's eyes like that, one open, one close. How? And then arms like that. How? And then Moto, he's sometimes saying his name, sometimes he's saying Amitabh Bachchan's name. What is happening? Okay? Alright. So difficult to assess. You're going to waste time. So what we put into place is response, a simple mnemonic to find out whether how is the patient's level of response. So what is the mnemonic in place? AFPU. AVPU. Not passing urine. Okay. AVPU. Okay. What is AVPU? A, alert. V, okay. So before you go and tap the patient is already alert. Okay. You go tap in, the fellow will slap you. Okay. Alright. So he's already alert. He's alert. He can talk to you normal. Okay. That is alert. V is verbal. You have to tap. Then he wakes up. And then he can talk to you. Okay. So verbal response. How about P? Pain. He can only respond to pain. How are you going to elicit pain here? So the sternal is more GCS. And it's quite brutal, right? Have you seen him doing like a sternal is going to fracture, You can just pinch the fingers. Just a slight pain response from the fingers. Okay, just pinch the fingers and then see whether the patient withdraws his hand or not. So that will tell you that patient has response to pain. Unresponsive, despite pain, patient does not respond. So that is unresponsive. Why is it important to know about this response? If patient is alert, what does it mean? The airway is patent. Patient can talk to you. That means chances are there's nothing much in the mouth. Okay? Alright. If verbal, what does it mean? And what is the other thing about alert? If patient is already awake, can talk to you, okay, there's no airway, there is no airway obstruction. But what is more important than that? Patient's conscious level is good, which means a bit unlikely patient is to have a neurological problem. Patient might not. A bit unlikely patient has a head injury. Okay, the chances of head injury is a bit unlikely because patient is fully conscious, can talk to you, is awake, fully alert. All right. So that's why we always write, like a robot, alert and conscious, alert and conscious, alert and conscious. Why? Just to tell you that patient most likely has a good awareness. Okay, his reticular activation system is firing nicely in the brainstem. Okay. Oh, makan tak pagi ni? Okay, better. Okay, alright. Now, how about verbal? When you patient has to wake up, directly talk to you. What does that mean? Verbal means patient's airway is patent or not? Patent, he can talk to you. But what does that tell you? There could be some head injury going on. Maybe mild. Because patient's conscious level. When you come to the hospital, with the presence of the doctors with the white coats and the noise, are you going to be sleeping or wide awake? Wide awake, right? You'll be scared shitless, right? Correct. Excuse me for the language, okay? You'll be scared shitless because of all the lights. You won't be sleeping there and snoring, correct or not? If you are sleeping, something is wrong. That tells you that your conscious level is not so good. So there could be some mild to moderate head injury going on there. So you have to be a bit aware. How about pain? Could there be some problem with the airway? Could be, because patient is unable to talk to you. Patient only has response to pain. So there could be airway obstruction, but there is still some neurological response. That's why patient can withdraw from pain. Understand? There's still some neurological response, but also tells you that this patient could have a moderate to severe brain injury. You do not know. Alright? So immediately you need to assess the airway and you need to put into mind that there could be a neurological problem going on there. How about unresponsive? Your heart rate will shoot from 160 to 200. Okay? Your heart rate will shoot from 160 to 200. Okay? Because unresponsive can mean anything in the world. You don't know whether the patient's sugar is low, or is it because of head injury, or is it because of the doctor is too stunning, so many things. Okay? So problem. Okay? So that is why we assess this response. This response is so important. Okay? We don't do it for fun. We do it because we know that A and V, you can buy some time. P, something is really wrong. U is either you fight or flight. Okay? Fight or flight. You stay and fight or you run away. Okay? Now. Okay. So that's response. So response clear? Now only we go to macam demo royak tadi. A, B, C, D, E. Okay. So remember, primary survey does not immediately start with A. It has got few components before that, which you need to prepare, which always we often overlook. Okay? So danger first, PPE, role of your team, response when the patient first comes, which will dictate how urgent you need to do your primary survey. Okay. Don't worry about notes, you don't need to write. Everything is there in the notes. Perfect. Okay? Any questions up to now? No? Sleepy? Enjoying yourself? Very difficult to enjoy yourself in a class, right? It's different if it's, Okay, now we move to the components of primary survey. So primary survey, as I said, good things always come in pairs. Okay? Airway and cervical immobilization. Breathing plus ventilations. Circulation plus bleeding control or hemorrhage control. Disability plus neurology, or sometimes pupils. We put it as neurology. exposure plus environmental, and then followed by 2 plus 2 plus 2 plus 2, which is your adjuncts. Okay? Alright, don't worry, we will go into detail each part. Okay, so now we are going to move into airway plus cervical immobilization. Okay, so we will show on the patient what we are going to do next. Okay.